TopMedTalk.
Welcome to TopMedTalk. This piece comes from our live coverage of Anesthesiology 2022. It is the single largest gathering of anesthesiologists in the world and the annual meeting of the American Society of Anesthesiologists. Now, our live coverage is available now at live.topmedtalk.com. More details in the show notes. Don't forget to subscribe, and please help us boost our signal by sharing this podcast wherever and whenever you can. Well, hello, it's Anesthesiology 2022 here in New Orleans, Louisiana for the American Society of Anesthesiologists. TopMedTalk is here in the exhibit hall. It's booth 2245. I'm Desiree Chappell, your host, and I'm joined by my co-hosts, Professor Monty Mythen and Professor Saul Aronson. Gentlemen, good morning. How are you, Saul?
Good afternoon, and
Is
I'm
it noon?
great.
Almost. It's almost noon.
It's noon somewhere, so we're not here. But
Sorry, yeah. So lots of great conversations so far. This morning we started a couple hours ago. I think we've already gotten like 5 podcasts in, which is really
busy
really
morning,
good.
huh?
It has been a very busy morning. Monty, how are things been for you this morning so far?
they were great. What a great, strong start. I was actually on a podium presentation with some of
Yeah, my colleagues.
your colleagues and partners talking about intraoperative hypotension, a very large data set that 2 major anesthesia groups worked together to produce, and some quite surprising and shocking results. We just did a podcast about that, so people can listen to that soon.
Yeah.
Where can they listen to that?
At live.top. Well, we can't listen to that
No.
one now. Now, if you want to watch the live stream, it's live.topmedtalk.
Yes, we are live streaming this entire event all
wow,
weekend.
yeah.
Now, the podcast will subsequently then go up as quickly as possible at either topmedtalk.com or live.ebpom.org.
Yes.
I can't remember it.
I know. It's easy. Just go to live.topmedtalk.com. You'll get everything that you need to know there. It will send you on to all the relevant places. EBPOM, just for people, we mentioned EBPOM, Evidence-Based Perioperative Medicine. Monty, 2 seconds on what EBPOM is.
EBPOM, Evidence-Based Perioperative Medicine, was started by myself and colleagues in London about 25 years ago. It's subsequently developed a global presence to share interesting conversations about evidence-based perioperative medicine, and we think by being light touch and a big church and open arms and lovers,
That's right.
collaborators, that it's been very successful.
Yeah.
So you can't, you know, there's no infrastructure. You can actually now get a modest membership
Yes, to EBPOM.
to EBPOM, which gets you into our platform, that gets you all the pre-recorded lectures. And depending on where you work, if you're in the UK, for example, you can get your full year of CME points just by your membership of EBPOM. Yeah.
Did I hear 25 years? It's a quarter of century?
Yeah.
It is for EBPOM.
So now, wow.
Well, it's not enough. We're going for the big 50. They're getting it. Yeah. The drugs are coming.
That's
wow.
right.
Wow.
Yeah.
Exactly. We're going to defy aging. Somebody defy aging.
that way. Yes.
We're in first, aren't we?
Yeah. Get behind me.
Well, we've heard him. You can see him, Dr. Kamal Maheshwari. Thank you so much for joining us today. This is going to be
my
a
pleasure.
fantastic conversation. It's actually a follow-up and more conversations from last year. You joined us last year on TopMedTalk, didn't you?
Yeah, that was pretty exciting, and it was nice to kind of discuss in an informal setting.
Yeah.
With the work which you do, and with some emotion also. I guess. Damn it! I was like, rather than on paper, you cannot show that
Your
emotion.
enthusiasm and passion.
So
Everything we do is informal and emotional.
I like that. Exactly. That's what the like.
Yeah. Kamal, we'll jump in just 1 second, but I did want let everyone know that TopMedTalk is free, open access to the world. You knew that. We tell everyone that, but we can't do that with the support of our generous sponsors and industry partners and organizations. So Edwards Life Sciences, Medtronic have all been platinum sponsors for us throughout our time as TopMedTalk. But we really wanted to thank the American Society of Anesthesiologists.
Absolutely. They've given us this beautiful space to work out of. Now, we'd say completely free, open access medical education. So 100 countries around the world listening on a regular basis.
Wow.
So very many places who can't afford to get to meetings like this, we bring the conversation and the lectures to them completely free.
Yeah.
And thank you to the sponsors. That's what makes it possible, and for people to give their time up generously to have conversations.
Well, that's what I was just
100
saying.
countries.
Yeah, and
It's amazing effort.
Yeah, well, and I mean, what we'll hear in this conversation is actually a highlight from the ASA meeting. So it's wonderful. We have another platform, another way to express emotions about the presentations that you have, and that we can share what's happening here in New Orleans to anyone, no matter where you are in the world. So excited about that and want to thank the ASA. Now, Kamal, for those who may not know you, which I don't know who wouldn't know you, but there may be a couple people in different corners of the world, tell us just a little bit more about yourself and kind of the work that you've been doing in the past.
Yeah, so I'm an anesthesiologist at Cleveland Clinic. I'm a liver transplant anesthesia. That's my specialty. But also, my last 7-8 years have been focused totally on outcomes research. And the goal was that what we do on a day-to-day basis can be guided with evidence. Mm-hmm. So that was the sole purpose. And now the work which is going on in the different aspects of how you improve outcomes of surgical patients. And my specific area is hemodynamic management, where we are doing trials not only in large databases, but also into predictive modeling, predictive softwares, and what's the future in that comes out to be. So the goal is, guide your day-to-day clinical care with evidence and data.
Yeah. So you're at the Cleveland Clinic, which is a very famous brand now of delivery of healthcare, because we've got one in London now. so therefore you're in the mothership, aren't you? Which is the
So I'm in the Cleveland Clinic, Cleveland, Ohio,
yes.
and I was fortunate enough that this past few months to visit Cleveland Clinic in London. Beautiful.
So they're around the world and around the USA, but the mothership as such is in Cleveland, Ohio.
That's correct. That's correct.
Yeah. So, Kamal, tell us about you. You present. You have multiple presentations and different things that you're doing here at the ASA. Tell us a little bit about some of the work that you're presenting here this weekend.
Yeah. So we can go by chronology. So which worked with today, this morning, and so two things I will bring it up, which I wanted to share in this conference. One is the risk prediction. So risk prediction is key, not only for hospital resource management, but for clinical research also. We want to highlight or work on patients, and specifically high-risk patients, and make specific interventions for them. And accurate risk prediction is very difficult. And so one of the work which we presented today, it was based on National Medicare data, which is CMS. It's a risk stratification index. And the risk stratification index, third generation, was the work which we presented, in which we predicted at admission, when a patient comes to the hospital, be it for surgery or general admission, we predicted that 10 different outcomes, including length of stay or excess length of stay, mortality, and specific outcomes like sepsis, pneumonia, and AKI.
So this is Sol space, so he'll come in with a few questions about that in a second. But just to be clear what we're talking about, we recognise, for example, assigning an ASA score. Yeah. That is a version of, although very helicopter, that's a form of risk prediction, of risk stratification.
Absolutely. No, absolutely agree. So, like, even by age, we know that certain patient, older patients are at a high risk of complications. The question is how you bring specificity to that at the individual level. How you say this patient this morning came for a surgery. What is the risk for this patient?
For this patient, not the population that you're in.
So
the person.
Exactly. That's what the 3.0 we call it. And this is now published last week in Anesthesiology. So now the full paper is available with broad suite of maths, which part of it I may say that I don't understand part of it also, because the AI experts basically who helped develop this thing.
So, but if you're going to dig that risk predictive modeling down to the level of an individual patient, specificity and sensitivity is really important, because you're not talking about populations where you would allocate or presume to make decisions about resource storage or gathering.
Exactly.
But you're looking at an individual patient. How do you reconcile, if you will, anything less than perfection of sensitivity and specificity at an individual level?
Exactly. I mean, I think one way we have to start answering that question is that we know an average incidence of certain thing, right? That's our baseline knowledge. We know that, incidence of, let's say, AKI is 4 to 8%, right? Now, any model which you're going to bring up, how much you improve on top of it, that's one way of thinking about now AI modeling, which is going on. Now, specifically in the RSI, any basic model.
RSI?
risk stratification index.
Okay.
So this was the work which Cleveland Clinic has done for the last 10 years in collaboration with Health Data Analytic Institute, and the 3.0 version. And there's 100 papers, with some kind of validation and usage there. But 3.0 is specific. It's special because we took 1 year history of a patient to predict at the time of admission to those things. So that's a unique thing. We also extended the models from surgical patient to the all hospital patient. That's a unique thing. And also we use 6 different machine learning approaches and compared with the traditional logistic regression modeling and presented that information. And the goal was that I want to know about a particular patient, what is going on for that. So the analysis which you do, I don't want to throw too many terms, but I do want to say that the models has to have a good discrimination. The model has to have a good calibration.
So I can see where this is going to go, and I know that if we had a few hours solved, we could write it. So now you're better at saying, there's a reasonable chance you're going to crash. But the good news is we know when and where you're going to crash.
Yeah.
Whereas I'm guessing what we're going to hear now is, couldn't we just stop you crashing?
I wish. So the current evidence.
Darn it.
Current evidence.
I thought you were in this.
The so-called current evidence-based medicine is into, one is predicting, number 2 is detecting early any complication, and third is when you find something, can you treat it, right? So in the prediction world, we are making some successes, but on the intervention side, we don't know exact mechanism how to treat AKI. So, that's where I would say where we are right now.
Okay. So it's the right journey, of course.
Exactly.
And I could jump right to the end first and say, how far are we from the finish line? Because at the end of the day, that's the question.
Yeah.
The other part of that, if you will, question logic is if we learn that sick people do less well than healthy people, and well-managed sick people do better than poorly managed sick people, why don't we just do the right thing all the time for everybody?
Yeah. So we want to do the right thing all the time. Clinicians want to do it, right? It's just the information lag. So at the time of decision making, sometimes we don't have that information. Like in the pre-op clinic or other areas, when you're trying to make a decision, I don't have that precise information that this patient is high risk for pneumonia and I should go for this consult, that consult, I should optimize this way or that way. And that's where the AI gonna help, because you're gonna have the tools at the level when you're making decision, right? It is not after the fact. It is not like, things are good or bad. And our goal is to develop. And we decided the timeline is in century, quarter of century. So
we've got 25 years to go.
So
things move slowly.
I hope when the whole community work together and we are trying to solve a part of the problem, like everybody work together, and we're going to reach our destination together sooner.
Okay. Well, yeah, I would love. Let's continue your journey, because you've done a lot. You've done a lot, but I know that there's a couple things we want to make sure we touch on. Other things you're presenting today.
Yeah. So the second part is especially on hemodynamic management, right? So that's my area which I've been working for quite some time.
That you would like to be emotional about.
Yes, I'm emotional about people. Please take care of this thing. And in that, we have worked on, we have shown in the past so many years that hypertension is bad, it should be avoided. Then we said that how you should avoid, we said that, we should predict hypertension. So we worked on predicting hypertension. So now that is solved problem from my perspective. And then from prediction, you have to go to appropriate treatment. The work which we showed here is that, the predictive models, whenever we work, you have to show that they work well in all different contexts, right? And that's why you say that, there are 100 studies on the same thing. Yeah, because people are trying to do the right thing for each and every context. And so hypertension prediction index, we have shown that it just works in, from invasive, non-invasive waveforms.
Across the board.
Across the board, they work well. But the question is, in certain patient population, hey, what about liver transplant patient? I was like, liver transplant patient, we are the national leader in liver transplant in the United States. So, and we we apply the hypertension prediction index at that level and evaluate it.
And for our watchers and listeners who haven't seen a liver transplant, there's a lot going on.
There is.
There's a lot. If you're a sailor, that's a big sea.
Yeah.
If you're flying, that's flying through a storm.
But before we get to that, because it's the obvious, it's almost too, in the spirit of the baseball playoffs, a big fat hanging curveball. let me ask you something first.
Sure.
Which is trying to meld, if you will, our first discussion with this one. In the context of liver transplant, complex surgical procedure, a lot of acute, shifts in fluids and hemodynamics. Are there things that you can predict preemptively based on your predictive models that would highlight you to the likelihood of that patient having hemodynamic instabilities given the surgical specificity of the procedure itself?
Absolutely. So their work from our group and other group from my colleagues also. Like for example, I'm saying diastolic dysfunction on echocardiogram on the pre-op. If the pre-transplant patient have a diastolic dysfunction or a systolic or any evidence of cirrhotic cardiomyopathy, they're going to do worse, right? So people have built models into predicting and then say that do something more for these patients. So that's just one example for that particular context. The cirrhotic cardiomyopathy is the bigger, fat curveball, what you mentioned. Like it is there. And so we want to optimize that. So, okay, if any solution we want today, okay, people who have those cardiomyopathy, now you go all in to prevent whatever you want to prevent, right? So that's the goal, that you can predict which patient's gonna do bad patients, right? But now during the surgery, what you should do for them, then you have to kind of go into these kind of scenarios that, you want to optimize, for example, perfusion of certain organ, or you want to optimize blood pressure, you want to optimize the use of vasopressor, you want to optimize the cardiac output. That's where the science is going right now.
And is your liver transplant work a free paper here? Is it an abstract or is it a presentation you're doing? Or
it's an abstract. It is under review in a journal.
Okay, so people can see the results. The executive summary, it works. Is it?
Executive summary is like as you said, liver transplant is too many hemodynamic variation, and we said that why not throw HPI into this? Like, does it work or not? Number one, yes, HPI predicted hypertension even in the liver transplant patient. So that's number one. Number two, whenever we always have secondary outcome. I want to see this, I want to see that also. We said, does the cardiac output, which we measured from the software, because we had the PA caster, is aligned with that, or SVR is aligned with that. It was only, the data we had very limited because we have only not more than 150 pairs to study with. So it's pretty early. And in that, I cannot make any judgment with confidence. But there was a wide variation, as rightfully said. So the point, what we were testing is that, does HPI work in this extreme situation or not? And the answer was yes.
So if people are interested in more detail, the abstract's available online, et cetera, et cetera.
Yes.
Yeah. So Kamal, you had that presentation. What else kind of work are you working on right now?
my current focus on, in fact, I think I have made a decision for my next decade of focus.
Oh.
Boy, when you're my age, you just don't talk about decades. It's sort of a time aliquot.
You guys reset my timeline. But I think the going forward is just point of care decision support system.
Oh.
Okay.
And that we have to build.
Yes.
We have to reduce the variability, be it the care of a patient provided in the United States, in Cleveland Clinic or Cleveland Clinic London, or in India or in Africa. And the way you can do this thing is building, using technology, and using technology to build point of care decision support system. So if any person should be able to follow that guideline everywhere. Now, that will be dependent on the type of data which you're working with, but that's the goal. And it can be built, and that's the goal.
Yeah. Well, in the world of anesthesia, many clinicians don't like it necessarily whenever people tell them what, or people or maybe computers tell them what to do and how to deliver anesthesia. Do you think that's going to be a hurdle that you,
I think,
or a barrier?
I chose the word carefully as a decision support system. The idea is that you help me reduce my cognitive burden. You help me do my job better. If anybody is helping me doing my job better, I don't think I should be kind of pushing it away. So that's how we should see the technology. We should use the technology. In fact, as implementation science, that's how we should develop the technology as a decision support system.
So are you ready for the loop to be closed with your vasoactives and your fluids and your depth of anesthesia? Are you a embracer or a pusher?
I'm totally
pusher away.
I'm embracer, as I said, that as a decision, because as a decision support system, right, and with good, what do you call, evidence, right? So we are getting there right now, and I think eventually it's going to happen. Like there will be some decisions. For example, in the car, cruise control is a decision support system.
Pilots and autopilot,
and they're there. And
you've got a car that drives itself, haven't you? Solar.
Pretty much, it's a battery and an iPad.
Lane. We always say lane. Lane correction.
Exactly.
Autopilot.
So this is the right way to think about it. Is that I'm still in the driving seat, but I'm getting help into suddenly I was veering off.
Keeps you in your lane.
Keep you in the lane. You have a cruise control, adaptive cruise control, so that keeps you in the right distance. So those are the things which will be automated closed loop at that level, right? And yes, you would. I mean, at this point of time, neither our data or neither our technology have reached to the stage that we are ready to kind of like full self-driving car.
It's a perfectly excellent metaphor. I have a friend who has a plane, and we just got back from a little golf trip. But I just so much remember once we took off going on autopilot, we could override it if we want. He let me fly the plane. It was okay, and then I went back on autopilot.
It worked out. He's here.
But the point being, you need a pilot with expertise to take off and land. I don't think that's ever going to change. But I say that with hesitation. But I see our systems of delivering, care in complex medical environments to follow the path of other industries.
Yeah. And it's going to happen. It's going to happen because the data stream is getting better, right? And the technology, which is like the point of care decision support system, they are getting better. Like how you interact, how the information is going to come back to you. And is going to overall help in providing safe care. And the question is like, that should be the goal. We are providing safe care. That is the goal. And whatever it takes, whatever helps, where the science will go, where people are going to go.
Yeah. So what do you say to the pushers? Get over it?
Yeah, absolutely. I mean,
pushbackers, if you say.
Pushback, yeah.
I mean, like,
as opposed to the pullers, I guess.
So you talk about industrialization, you talk about like printing press, you can do the case studies over and over.
It's inevitable.
It's inevitable.
Yeah.
It is.
And it's cool. You can embrace it. Yeah.
Embrace it and be in front of it so that you can guide it, right? Use your mental power to guide this thing rather than to block this thing.
Farmers were worried about when the development of the combustion engine, but it's actually the horse that went.
Yeah.
That was the thing. There's quite a history about what happens at those various different stages. There was the horse. The numbers reduced dramatically for working horses
Yeah.
when tractors came.
And we should be humble enough.
Robots.
And we should be humble enough that we cannot predict the future to the extent nobody people who initially started the printing press or industrialization, people who are there, they exactly saw this whole path in like whole clarity.
Yes.
You never knew like how far it's gonna go, but you do it for the right reasons, and the patient safety is the right reason.
Yeah, absolutely. Well, Kamal, just wrapping up here, what should we be on the lookout coming out from the Outcomes Research Group and some of the work that you're doing? You said the HPI paper on liver transplant. Anything else?
And so risk stratification index, the anesthesiology paper is out, and then we are also doing out-of-sample validation and different states data for all pairs. So that is going to be a good supporting paper coming along with it. Then the important thing which we are doing is some trials, clinical trials, especially in the hemodynamic area. We are trying to figure out an appropriate treatment, and in a randomized trial, one is the SMART BP trial, which is going on right now.
Appropriate treatment for intraoperative hypertension, hemodynamic instability.
Exactly. The SMART BP trial is not only, so the goal is to predict hypertension, prevent it, but prevent it with appropriate treatment. You cannot just do vasopressor and prevent hypertension and then assume good outcomes going to happen. You cannot just flood the patient with fluid, then assume you avoided hypertension and then expect good outcomes. So the goal is that appropriate treatment is also a key in the whole puzzle piece here. And we are pretty excited. It's a national multi-center trial, and I'm looking forward to it.
Yeah, great.
So a quick plug for EdPom London next year. That's our sort of original iconic meeting, gone over its 25th anniversary. There's going to be the main congress next year is about prehabilitation. It's the World Congress of Prehabilitation. But we're having a side show for the hemodynamic geeks. So
That's a side show.
We should have a prime show.
No, it's going to be the thing to be at. So each afternoon, day 3 days. First afternoon is perfusion or pressure.
Yes.
We're going to deep dive on that.
Oh, yeah.
Day 2 is the right heart. And day 3 is artificial intelligence.
Oh, my
we
God.
have a good AI group in London.
You're going to be in London, aren't you?
Yeah.
This is the area which we have.
Consider yourself invited. Come on.
All right. Consider you listening to me.
Well, I hope to see you in London and hear part of that conversation. That'll all be on EdPom, our EdPom Educational Hub. Kamal, thank you so much. It is always such a pleasure to hear what you're doing. Just impressed, and congratulations on the work.
No, it's impressive. I think we live among all the, lot of experience which is there.
Walking on the shoulders of giants, standing on the shoulder of giants.
Yeah, that guides us going forward, basically.
Yeah.
Congratulations on what you've done and what we expect you to do going forward.
In the next decade.
And congratulations to the Cleveland Clinic for opening in London.
Oh,
yeah,
there we go.
There you go.
Another world force.
All right, sir. Thank you.
All right. Well, thank you so much for listening to TopMedTalk.
TopMedTalk.
Do check us out for our live stream from Anesthesiology 2022, live.topmedtalk.com. You can hear all of our amazing conversations live during Anesthesiology 2022. You can find the schedule for all of those at live.topmedtalk.com. Cheers.